Assalamu alaikum everybody. My name is Dr. Rahim Ahmed. I am a consultant pediatric critical care physician at the Indus Hospital, and I would like to welcome you to the presentation for today, which is approach to arterial blood gas interpretation. Before we start, let us overview how we are going to proceed with this presentation. We are going to discuss the need for an arterial blood gas, the procedure or the basic precautions that we have to take, some basic terminologies, characteristic of a basic arterial blood gas disorder, and how we analyze the blood gas. First of all, we'll discuss the indications for doing a blood gas. If we have to assess the oxygenation status of the patient. If the patient is on some kind of ventilatory support, we have to assess its adequacy, or we have to see what kind of a acid-base disorder the patient has and how will we diagnose it. So that for that we need an arterial blood gas. The procedure is quite simple, but there are some precautions that we need to take. We know that the sites that we use to prick the patient for an arterial blood gas includes the radial artery, brachial artery, and the femoral artery. Once the sample is taken, the sample should be collected in pre-heparinized syringes. Pre-heparinized would mean that some amount of heparinized solution is taken and the solution is coated on the walls of the syringe and then discarded. Make sure that we do not leave any excessive heparin in the syringe because excessive heparin would cause dilutional effect and decrease the carbon dioxide or the PCO2 level, and in short the blood gas will not be appropriate. Other precautions would include that there is no air bubble in the blood gas syringe because the air bubble would mix with the blood and the PO2 would rise and the PCO2 would fall. Lastly, whenever the blood gas is taken, the sample should be immediately transported to the laboratory or the blood gas machine. If the immediate transfer is not possible, it should be stored in an appropriate iced storage bottle so that the pH and the PCO2 does not change. As mentioned in the slide, if we do not store the samples in an appropriate area and we keep it at room temperature, the pH would drop or change every 10 minutes. The PCO2 would also change and the PO2 would change. Thus, the results of the blood gas will not be of no clinical significance to us. The next part of the presentation is assessment of some basic terminologies and definition. What is acidosis? It is the process in which there is decrease in pH by the gain of hydrogen ion or loss of bicarbonate. Alkalosis, on the other hand, is a process which tends to increase the pH of the body by decreasing in hydrogen ion or gaining of bicarbonate. When these changes cause reduction in the arterial pH or an increase in arterial pH above the normal range, this is called as acidemia or alkalemia. What is a simple acid base or a primary acid base disorder? A single primary process of acidosis or alkalosis due to an initial change in the PO, CO2 or bicarb is called as a simple or a primary acid-base disorder. When the normal response of the respiratory or the kidney starts after the simple acid-base disorder, this is called as a compensation mechanism. When there is presence of more than one acid-base disorder in the body simultaneously, this is called as a mixed acid-base disorder. So what are the characteristics of a primary acid-base disorder? First, we will see the metabolic component and then go on to the respiratory component. What is metabolic acidosis? As we know, in acidosis, the pH of the patient is going down and the hydrogen ion is increasing. The primary defect is the decrease in the bicarb level. How does the body compensate? It decreases the PCO2 by alveolar hyperventilation. Similarly, in metabolic alkalosis, the pH is increasing and the hydrogen ion is decreasing. The primary defect is there is an increase in bicarb and the body compensates by increasing in the carbon dioxide level by hypoventilation. What is respiratory acidosis? pH is decreasing of the patient. The bicarb the carbon dioxide level is increasing. Similarly, as a compensation, the carbon dioxide to the increase in carbon dioxide, the bicarb level starts to increase. This is called as respiratory acidosis. What happens in respiratory alkalosis? The pH is increasing, the PCO2 of the patient is decreasing, and as a compensation, the bicarb starts to decrease. This is respiratory alkalosis. So, these are the four basic primary acid-base disorders that we see in a patient. Along with that, what is compensation? As we discussed before, compensation of the metabolic disorders. How does it take place? By the changes in carbon dioxide. If there is metabolic acidosis, there is a decrease in the bicarb, for which there is a decrease in carbon dioxide level. The exact value of the PCO2 that we see in metabolic acidosis can be calculated using the mentioned formula, which is called as Winter formula. What happens in metabolic alkalosis? Similarly to metabolic acidosis, but in the reverse direction, as the bicarb of the patient increases in alkalosis, the PCO2 increases. The exact value can be calculated from the formula that is mentioned in this slide. For respiratory disorders, when the PCO2 changes, the body compensates, and the organ that compensates is the kidney by decreasing or increasing the bicarb reabsorption. However, the kidney compensation through respiratory disorders is usually slow. It starts slowly by after around 6 to 12 hours, and the complete compensation may take up to few days. So, always remember in respiratory acidosis, when there is an increase in carbon dioxide, as we discussed, the bicarb will increase. So, initially in the acute phase, the bicarb will increase to a smaller extent, as mentioned in this slide, by approximately 0.1. However, when the respiratory disorder is chronic, that is for at least 24 hours or more, the bicarb level increases to a more significant level to approximately 0.35. Similarly, in respiratory alkalosis, when the PCO2 decreases, the bicarb decreases. However, once the disorder becomes chronic, the amount of bicarb that decreases with each decrease in the carbon dioxide is more and more significant. After discussing these discussing the terminologies and the precautions, let's see how we should stepwise approach to interpret the blood gas. Before we start the basic steps, let us review in this slide what a normal arterial blood gas would look like. This is an arterial blood gas, normal values. These are not values of venous or capillaries blood gases. So the step one, whenever we get a patient's blood gas, what we should do? We should see the pH and see if it is acidemia or alkalemia based on the pH. Any pH below 7.35 would be acidemia, and any pH above 7.45 would be alkalemia or alkalosis. So the next step is to see if it is respiratory or metabolic. What is the primary disorder? If the pH and PCO2 are rising or falling in the same direction, that means the disorder is primarily metabolic. However, if the pH and PCO2 are going in the reverse direction, either increasing or decreasing, that would suggest the disorder to be respiratory. If we identify that the patient has a respiratory disorder, the next step would be to see if the issue is acute or chronic. How we do this? If the respiratory issue, first we take out delta PCO2. What is delta PCO2? It is the difference between the patient's PCO2 and the normal PCO2. Then we take out what is the difference between the pH of the patient and the pH of the measured and the expected or the ideal pH. So the differences, we are taking it out and we are using in putting these values in these equations. So if we are multiplying the difference in PCO2 by 0.08, we will get a value from which we will calculate the acute pH of the patient and the difference in the pH. So if our sums or if the results of the calculations are similar or nearer to the above value of 0.008 in this slide, that means the patient has an acute respiratory disorder. If the values are similar to the sum of the product of 0.003 times the difference in carbon dioxide, we would say that the patient has a chronic disorder. If the values in between arise, that would show that the patient has either a partially compensated blood gas or if there is a mixed disorder. So to see if the compensation is adequate or not, we use these formulas as mentioned before also. So if the metabolic disorder is metabolic, we see the expected PCO2 and the measured PCO2. The expected PCO2 in case of metabolic disorder would be from the slides shown previously, in which there was winter formula utilized for metabolic acidosis and the other formula used for metabolic alkalosis. So if the PCO2s are correlating or nearby, that would mean that the patient's compensation is complete and adequate. However, if they are not matching, that would mean there is inadequate compensation or there is a disorder which is mixed. Similar for respiratory, as mentioned in the previous slide, we will measure the pH and see the difference. If the difference is closer by to the acute or chronic, that would mean that the patient has adequate compensation. Otherwise, the patient is having a mixed disorder. So this ends the discussion on respiratory component. If the patient has a metabolic disorder or a metabolic acidosis or alkalosis. So for metabolic acidosis, the first step would be to calculate the anionic gap. Why is this important? What are anions is the next question. Anions are negatively charged ions in the body and cations are positively charged. There are significant anions and cations in the body. However, for our calculations, we only use major anions and cations, and other non-significant values are usually ignored. So, in the patient, in a normal human being, the number of anions is greater than the cation, therefore, a anionic gap exists. When calculating the anionic gap, we calculate it by the mentioned formula in which we use sodium and we minus it from the sum of chloride and bicarb. This is how we get an anionic gap. The normal ionic gap is approximately 12 plus minus 4. However, sorry, when calculating the anionic gap, we have to calculate the difference in the patient if the patient is hypoalbuminemic. Because when there is a decrease in albumin, there is a decrease in anionic gap. So always consider albumin when calculating and labeling a patient with an anionic gap to be normal or increased. So if the patient has a normal anionic gap or a abnormal anionic gap or a high anionic gap, these are the two things that come up in the metabolic acidosis. So if the patient has high anionic gap metabolic acidosis, these are the differentials that we are known. This mnemonic is for mud piles, and the causes of high anionic gap metabolic acidosis are mentioned here. The next step for any patient with high anionic gap metabolic acidosis is to see if there is a coexisting metabolic disorder which is quite frequent. How we do this? The steps are very simple. We calculate the delta anionic gap, which is the difference between the measured anionic gap and the normal anionic gap. Then we calculate the next step is delta carbon dioxide, which is the difference between the normal bicarb and the measured bicarb. Ideally, anionic gap should be equal to the difference in the bicarb. However, in situations, there may not be the what is ideal. So if the ratio or the difference between the division of anionic gap and bicarb, delta bicarb, is 1, that would mean there is no other additional issue and the patient just has pure high anionic gap metabolic acidosis. However, if the sum or the ratio is less than 1, that would mean there is an associated normal anionic gap metabolic acidosis the patient has. And if the product or the sum is more than 1, that would mean there is an associated metabolic alkalosis. I hope it is clear. Always remember this gap or the steps to calculate if the patient just has high anionic gap metabolic acidosis or there is a coexisting simultaneously occurring disorder. This anionic gap and delta anionic gap divided by delta bicarb is one of the methods that we use. There are other methods also available, but we are focusing on only one method. So if the patient does not have an high anionic gap metabolic acid, that would imply that the patient has a normal anionic gap metabolic acidosis. For these patients, we calculate the urinary anionic gap, the formula for which is slightly different as mentioned in this slide. The values for urinary anionic gap can either be negative or positive. If it is negative, most likely causes would include diarrhea or proximal RTA. However, if the patient has a positive urinary anionic gap, this would mean that the patient either has type 1 RTA or type 4 RTA. Lastly, last of the basic acid-base disorders is metabolic alkalosis. If the patient has metabolic alkalosis, we check urinary chloride and see the value if it is less than 10 or more than 10. Less than 10 would mean that the patient is chloride responsive. That is the patient is losing the chloride because of loss of body fluid. That would mean that the patient has significant amount of either diarrhea or vomiting, or there is angylosis, or there is diuretic abuse. However, if the patient's urinary chloride comes out to be more than 10, then the patient does not have any significant losses. The patient chloride is more because of excessive body fluids. That would mean the patient might be having either Cushing syndrome or hyperaldosteronism. So this, my friends, brings us to the end of the presentation for approach to acid-base disorders. I hope mm, the presentation is clear to you. If there are any questions, please feel free to ask. Thank you.